Aloha and welcome back to our series, Nursing and the Human Body. Today, we are going to take a deeper dive into the study of congestive heart failure. So let's get to it. Congestive heart failure is a common debilitating condition defined by the heart's mechanical inability to pump. So here we see a normal heart. And we have kind of looked at this before. We said that in our intro to perfusion lecture, we said that in a normal heart, we have an ejection fraction of about 70%. And what that was measured by was we said that our cardiac output was determined by our stroke volume times our heart rate. And so you can see here in this example, we've got a preload of 100. Heart is filling up with 100 mLs of blood. And we've got an afterload of about 30. And that's how much blood is left in the heart after it contracts. And what that means is with each contraction, right, we are ejecting about 70 mLs of blood, which is consistent with a 70% ejection fraction. So we said that preload was the volume of blood in the ventricle before each contraction. Okay. Volume of blood before contraction. And that the afterload was the volume of blood in the ventricle after contraction. Okay. After contraction, afterload. So again, we have our example here of a normal heart with a preload of 100, an afterload of 30, which is telling us that our ejection fraction is about 70 mLs or 70%. So Starlings Curve tells us that healthy hearts are like a spring, and the more filling results in a more contractile force. So in a healthy heart, more filling equals more force. And here's our normal heart. But in dilated cardiomyopathy, we have a thin, weak, floppy heart muscle. So let's take a look at that animation again. Here's the normal heart, and we can see there's a little slice of it removed, and we're kind of looking in on the ventricle. We see that in dilated cardiomyopathy, the ventricle gets much bigger, and what we have is a weakened heart. And so we have a low ejection fraction, we have a low cardiac output, and we have a high preload and afterload because we have a really stretched out ventricle. And so in dilated cardiomyopathy, what we will see, and this is an example of that, what we would see is that we can see that our preload is very high, right? It's over 100, okay? And our afterload is also quite high, right? We have a really low ejection fraction. We're only ejecting about 25% of the blood with each heartbeat, okay? And so Starling tells us in this case, just like springs, if the heart is overstretched, it loses its capacity to return force. So more filling actually results in less force. Okay? And so we gave the example before that we thought about stretching a slinky, right? Now normally we pull a slinky apart and it springs back together really nicely. But if we overstretch a slinky, as we all have done or our children have done at some point or another, it doesn't work anymore. It doesn't return force back into itself because it's gotten overstretched now and it doesn't have that nice springy effect. So again, here is an image of the normal heart. And here is an image of ventricular hypertrophy. So let's think about that word again. Hyper meaning more, a lot, right? Too much. Too much trophy is growth, right? So too much growth of the ventricle, which is thickened, okay? It's weakened. There's stiffness of the heart muscle in this case. And so what we see here in ventricular hypertrophy is actually a low ejection fraction, again, low cardiac output, right? And we can see here that our preload and our afterload are not way off the charts, right? We've got less capacity inside the ventricle for blood to come in. And then we have less blood coming in. We have a weakened heart that's not pumping efficiently. So we have a low amount of blood being pumped out. And then we have still blood left in the ventricle afterwards, right? So in other words, the blood it's coming into the ventricle, it's going out into the body, not very much of it, and then we still kind of have blood left in that ventricle after the heart pumps. And so in this case, we're getting a situation for the heart being too stiff, okay? And so just like the springs, if the heart is too stiff, it really loses its capacity to return that force. And we've got, we've got more filling, but we've got no more force of contraction, okay? So congestive heart failure results in a decrease of blood circulation, which decreases oxygen supply to the organs and fluid accumulation in the tissues. And there's a decrease in blood circulation, which results in fluid accumulation in the tissues, is called edema. And we can get pulmonary edema, which would be fluid in the lungs, but we can also have systemic edema, which would be edema in the legs. We often will see it in the lower extremities or in the body total. And this total body edema is called anasarca. So CHF can cause the lungs to fill with fluid, causing shortness of breath, difficulty breathing, fluid retention, and swollen legs. Okay? To add to all of this, we also have decreased blood flow going out to the organs in the body. So there are different classes of heart failure, and these are the New York Heart Association classifications of CHF. There's class 1A, where the patient is asymptomatic. There's no limitation in their physical activity. They have ordinary physical activities, and it does not cause them undue fatigue, heart palpitations, right, or dyspnea, which is their report that they're feeling short of breath. Although they may have other indications that they're having heart failure, we're not seeing it symptomatically in the patient yet. In class 2, it's mild. And so there's a slight limitation of physical activity. They're comfortable at rest, but ordinary physical activity does result in some fatigue, some heart palpitations, or some dyspnea, or shortness of breath, complaint of shortness of breath. In class 3, there's actually marked limitation of physical activity. They're still comfortable at rest, but less than ordinary activity causes fatigue, okay? Palpitation or dyspnea. So an example of how to differentiate between the two would be, ordinary activity would be, getting up, getting dressed, going out, shopping, living your life, buying your groceries, doing things that you need to do for all of our activities of daily living, right? In this classification, this class 3, what we're seeing is less than ordinary activity. So this individual becomes short of breath and gets tired just from like getting up and putting on their slippers and walking out to the mailbox to get the mail, okay? I mean, this is just a pretty simple activity, but they're getting short of breath from this. As opposed to someone who's getting fatigued and overworked from really trying to get up and do all the normal things that we are all accustomed to every day. In class 4, this is severe, and these folks are unable to carry out any physical activity without discomfort. So symptoms of cardiac insufficiency can be seen at rest. If any physical activity is undertaken, discomfort is increased. So for example, this individual will get short of breath really just from like sitting up on the edge of the bed, trying to maybe stand up and walk across the room. So eating can be exhausting for this individual. This is severe congestive heart failure. So what are the clinical signs and symptoms of congestive heart failure? Well, remember, the left side of the heart collects blood from the lungs. And so if there's left-sided failure, fluid is going to collect in the lungs. And this is pulmonary edema. So here we have an example of a normal looking chest x-ray. And here we have an example of what a chest x-ray would look like when there is an enlarged heart and fluid in the lungs. Okay, so this is pulmonary congestion. Signs and symptoms will be dyspnea, and this is usually the patient's complaint of I feel short of breath, I can't catch my breath. They speak in 1 or 2 word sentences. There's increased in their pulmonary venous pressure, and their alveoli can become filled with serosanguinous fluid. And so sometimes they will even cough up some blood-tinged sputum. Orthopnea is another word that you absolutely must learn, and this is dyspnea, or the patient feeling short of breath while they're lying down, okay? So lying down flat causes shortness of breath. And sometimes we will ask folks when they come in and they're being evaluated for congestive heart failure, how many pillows do you sleep with at night? And they'll say, oh yeah, I can't sleep unless I have 4 or 5 pillows propping me up. Or they'll say, yeah, I sleep in the lazy boy chair now because I can't sleep in my bed anymore because when I lay flat, I have problems breathing. Paroxysmal nocturnal dyspnea is when the individual wakes up in the middle of the night feeling suffocated. So they will come in reporting that, gosh, I wake up in the middle of the night and I have these like episodes where I feel like I'm being suffocated and I have to sleep sitting up. I can't sleep laying down at all anymore. And so these are things that we want to be looking for in the report of the patient who comes in. So congestive heart failure is failure of the pump to adequately perfuse the organs, and now we've seen that this includes removing fluids as well. So the right side of the heart collects blood from the body, okay? So if we have a failure on the right side, we can have edema. And edema can be severe and involve the entire body, and this is called anasarca. So here we see a baby with anasarca, and notice how the baby's skin is kind of shiny and taut. Notice in the other image, you see someone with lower extremity edema where there's weeping. The fluid is actually weeping through their skin because it's in their lower extremities. And so edema can be mild and localized, like pitting edema in the feet. And so pitting edema is graded a +1, a +2, a +3, or a +4. And here we see the pitting because what's happened is we've pressed in on their skin on the top of their foot, and there's an indentation where the nurse presses down. And so this looks more like a plus, maybe a +1 or a +2 pitting edema. The deeper the edema goes when you press in, the higher the grading of the edema. So there's +1, +2, +3, and +4. So other clinical signs and symptoms are fatigue, which we talked about. So following activities that are normally not tiring, right? And this is decreased cardiac output. That's why this happens. We have impaired perfusion to our vital organs. The patient will have anemia due to poor nutrition, also due to renal disease. And we mentioned before that they would complain of heart palpitations, and this is from tachycardia, the patient being tachycardic, meaning that their heart rate is way up above 80, in the hundreds, in the 120s. And this is sympathetic nervous system compensating, right, for the decreased cardiac output by increasing the heart rate. Okay, well, you know, we're not getting enough blood supply to the organs, so the heart is going to start beating faster, right? We will see changes in the skin color. There's poor perfusion. Sometimes the individual will have a dusky grayish color to their skin. Other skin changes can include the edema, the weepy fluid in the lower extremities, and their skin may be cool or damp. Behavioral changes. So let's think about this. The brain needs blood to process information. We said the brain needs glucose. And so if we have an individual with congestive heart failure, we talk about the organs that are lacking perfusion. We might see someone who is restless, who is confused, who has a decreased memory in congestive heart failure. And this has to do with poor perfusion, even to their brain. We can see weight gain from fluid retention, and often we will weigh individuals every day when they're inpatients in the hospital. We will teach them at home to weigh themselves daily to make sure that they're not retaining fluid. Daily weights are often ordered for CHF patients and may help guide the use of diuretics in the hospital setting. Late in the disease, though, we might see weight loss or anorexia may occur. And this is really just due to weakness, fatigue, exhaustion, and poor appetite. And so lab results that we will look for, one in particular that I want you to know about is the brain natriuretic peptide, or the B-type natriuretic peptide. This is the BNP. This is a protein that's produced by the heart and the blood vessels that helps promote diuresis. So let's think about this. This is almost kind of like another mechanism by which the body is saying, oh, there's too much fluid on board. And we have this natural way of kind of releasing this peptide that promotes diuresis. And so our BNP is usually elevated in heart failure, greater than 100. It can go greater than 400. We would have probably clinically significant problems happening in this case. But it can go actually much higher in a CHF exacerbation, much higher than 400. So during hospitalizations of CHF exacerbation, the BNP level hopefully will begin to decrease as the patient's responding to the treatments that we're doing to help take some of the stress off of that heart, take some of that fluid off the body, and so on. Patients can also have dysrhythmias. Atrial fibrillation may occur, and this is due to stretching of the atria, can cause alterations in the normal conduction pathway. So we could see dysrhythmias. Another concern and complication for congestive heart failure is left ventricular thrombus formation, which can result in a stroke. So let's think about this here. We've got an embolus could get dislodged from the heart and go up into the cerebral artery where it would block one of the arteries that supplies the brain with oxygen-rich blood. And if this happens, the patient will have a stroke if the clot is significant enough to cause tissue damage and stroke. Okay, so the right side of the heart collects blood from the body. So if there's right-sided failure, fluid collects in the body, and this includes the liver. The liver may become congested with venous blood. And so we call this hepatomegaly. Hepato meaning liver, megaly meaning large. Fluid backs up in the body, congesting the liver lobules with venous blood, and this may lead to liver failure. Also, renal failure. Decreased cardiac output may lead to renal insufficiency or renal failure. So one of the things that we want to make sure we're doing in our CHF patients is very carefully monitoring their intake and output. Make sure that they are putting out urine. We also want to make sure we're monitoring some labs that could indicate renal failure, like the BUN and the creatinine levels. So drugs to treat congestive heart failure. Diuretics, Lasix is going to decrease that fluid overload, right? Because it's going to get that patient increasing urination to get fluid off the body. It's going to help decrease that preload. But remember, when we give diuretics, especially Lasix, we have to monitor the patient's potassium level because we want to make sure that the potassium level does not go too low because they will be peeing out potassium as well. ACE inhibitors can help prevent scarring of the cardiac muscle, inhibits the formation of that vasoconstrictor, angiotensin II, remember that, reducing the systemic vascular resistance. Angiotensin II receptor blockers we've talked about. These also prevent the angiotensin II from stimulating the receptors that cause the vasoconstriction. Again, reducing SVR. Beta blockers like metoprolol and Coreg. These are used in stable symptomatic heart failure, class 2 and 3, thought to help decrease the O2 demands of the heart and decrease systemic vascular resistance as well. And our vasodilators, right, our nitrates, act directly on the smooth muscle of our vessel walls, helping cause vasodilation. Inotropic agents are important in the treatment, and inotrope is an agent that alters the force or energy of muscular contractions. Positive inotropes can increase the strength of muscular contraction, and so that's going to be good for our heart. A positive inotrope like dobutamine, an adrenergic agonist, can increase cardiac contractility and cardiac output as a result. Natricor has a positive inotrope effect. This promotes vasodilation, promotes excretion of sodium and excess fluid, natriuresis. So we would give this IV. This is a non-adrenergic vasodilator. And Digitalis or Digoxin. This is a drug that we give. It increases the level of calcium ions available for contraction of the heart muscle. It improves cardiac output and reduces distension of the heart. And this comes from the foxglove plant. However, we need to make sure we monitor our patients for digoxin toxicity, okay? We don't want the digoxin level to become too high. Gastrointestinal upset is one of the most common symptoms, so GI problems if our DIG levels are too high. Patients also might report visual symptoms, including like a yellow-green discoloration in their vision, like a halo effect that's got this yellow kind of glow to it. Cardiovascular symptoms such as palpitations, or tachycardia, right? Dyspnea, shortness of breath, and syncope, which is, fainting, right? And so in DIG toxicity, we also want to make sure that our elderly patients might be presenting with more vague symptoms where it's not so obvious. They may say they're dizzy, they may say they feel tired. The most important historical detail in evaluating the random DIG level is really the time that they had their last dose. So always ask important questions like, you're having a little bit of visual changes, you're feeling a little bit sick to your stomach, GI upset, you're on digoxin. When was the patient's last dose? So in end-stage congestive heart failure, if all treatments have really failed and we have cardiomyopathy, we have a patient who's being considered for cardiac transplantation, to get a cardiac transplant. And so this requires rigorous counseling. This is a huge surgery. This is a major commitment on the part of the patient and the family. You undergo quite a bit with the decision to go for cardiac transplantation. Want to make sure they fully understand all the risks and benefits and what will be required post-transplant. I'm not going to talk a whole lot more about that. What I really would like to do is just kind of review a couple of nursing diagnoses that you might use when you're caring for a patient with congestive heart failure. So activity intolerance related to fatigue, secondary to decreased cardiac output, as evidenced by increased shortness of breath on exertion, weakness, and states, I feel too tired to walk today, right? So we've got some data there that supports our nursing diagnosis of activity intolerance. What are we going to do? What are the nursing interventions going to be? We want to provide a quiet, restful environment for the patient. Sometimes we want to cluster care. This really depends. Clustering care is when you go into the room and you do several things for the patient and with the patient at one time. So in other words, you're not going in and out of the room frequently all day long, asking the patient to do things, working with the patient, because that can be tiring. On the other hand, we have to make sure that if we're going to cluster care, that we provide adequate rest periods in between our interventions. We want to allow the patient to set the pace. And of course, we want to give them oxygen per nasal cannula. This would be another type of nursing intervention for a patient with congestive heart failure who's having problems with oxygenation. Another nursing diagnosis might be excess fluid volume related to cardiac failure, as evidenced by bilateral lower extremity pitting edema, right? And we might quantify that, +1, +2, +3, and a weight gain of 5 pounds in 2 days. Okay? So this is evidence, right, that our patient is retaining fluid and has excess fluid on board. So that lower extremity edema and that weight gain. And a weight gain of 5 pounds in 2 days is actually possible. Now, it's really important that we are measuring the weight the same time each day with the same scale, and the patient will have on the exact same clothing. So it's really important to get accurate weights. Interventions in this case would be to give diuretics like Lasix, right? We want to try to get some of that excess fluid out. We want to be sure that we're monitoring and reporting weight gains or losses. and assessments like strict intake and output measurement, like we said before. We want to make sure that what's going in is equal with what's being excreted by the patient, what's coming out. We want to listen to their lung sounds, make sure that we don't hear evidence of fluid in their lungs on auscultation in the form of rhonchi or rales, or crackles, and daily weights, of course. And then, of course, monitoring the patient's labs. We've talked about several labs that we might be looking at, the BUN and creatinine to make sure we have adequate kidney function. We've talked about making sure that we're monitoring those potassium levels. That's going to be another lab. Monitoring the patient's BNP levels also. Okay. We may also put an individual on a fluid restriction. And what that means is they can only have a certain amount of fluid within a 24-hour period. So a fluid restriction is another intervention we might see. Another nursing diagnosis that would be appropriate might be anxiety related to paroxysmal nocturnal dyspnea, secondary to impaired gas exchange, as evidenced by they're using 2 or more pillows during sleep. They're saying, I'm afraid to go to sleep because sometimes I wake up and I feel like I'm dying at night. And also insomnia, right? They may come in and just say, I can't sleep, right? I'm afraid to go to sleep. And so we want to make sure that we are always explaining all procedures. And we have a patient in the hospital and they're feeling very anxious about what's happening. We want to allow them to express their feelings. We always want to use a calm and reassuring approach. We want to create an atmosphere to facilitate trust. If the patient feels more comfortable with O2 at night, we may use it at night, we may use it during the day, and of course that ever important diuretic therapy, which can also help get that fluid off, help them breathe better, and help decrease their anxiety as well. So that is our lecture on congestive heart failure. I thank you for your attention, and until next time, aloha.